Welcome everybody. We are going to go through GIT stuff today. And it's in a bit of a funny order because I did have to head off a bit earlier. So I'm going to be starting with I'm going to be starting with gut secretions, part 2. I think Alex is doing part 1. So what we're going to look at here is your bile and good stuff like that. So you guys have probably heard of bile. It is secreted by the liver, and it's got several functions and it's made up of several things. So its main function is to neutralize your gastric acids. So it's pretty basic, pretty alkaline. So that's how it neutralizes. And it also helps with your emulsification of fats. You guys might have done that last year in your biochem, the whole chylomicron thing. And it also helps with excretion of liver products. It's made up of mostly water, but it's also got cholesterol and derivatives of cholesterol. I'm going to go through the basic stuff here. There's like additional details in the speaker notes and comments. So I will leave that for you guys to read through because I can't view them both right now. But yeah, there's also lecithin, which is a phospholipid, and this is what actually helps you emulsify the fat. There's your proteins, amino acids, ions, and the one you really need to remember is bicarbonate because that's what helps neutralize your acids. You've got your bile acids and your salts, and bile pigments, which are actually products of heme breakdown. And key things to remember that they are bile is made in the liver and it's stored in your gallbladder. Okay, so moving on to emulsification and digestion of fats. I'm not going to go through the whole process, but a bit of a recap is emulsification is when you mix two liquids that you normally can't mix. And for this to happen, you need something called shaking contractions. So kind of think if you mix like water and oil in a cup and like you try to shake it. And that's done by your small intestine when it contracts. And also you need emulsification agent, which are your bile salts and your lecithin, which is the phospholipid we were talking about before. And the way it helps is bile salts and lecithin bind to the outside of the fat globule. So you can see here you have a big droplet, and you've got your bile salts and your lecithin that are binded that are on there now. And this prevents it from coalescing, so just breaking up, and coming back together when it breaks up. And then yeah, it splits, and you can see how they're kind of holding everything apart without it coming back together into one fat globule. Does that make sense? Okay. And bile, its secretion is regulated, so you can't obviously have bile secreted all the time because otherwise you can have no acidity left and your stomach can't do what it does and your duodenum can't do what it does. So there's a couple of things that control its secretion. So first thing is CCK, or cholecystokinin. That's released in response to fats in the duodenum. And this is it's released from enteroendocrine cells. You guys might have seen that. I know you probably haven't seen that yet, but yeah, that's just a cell type. And this causes release of the bile, which is stored in the gallbladder. And this is done by contraction of the gallbladder. And the bile comes out of a thing of the gallbladder called the sphincter body, which is kind of like here. But can you guys all see my mouse when I move it around?
Yeah,
we can. Oh, perfect. Yeah, so it comes out of there. And what bile does is basically just relax that. It also stimulates your pancreatic lipase production and inhibits your stomach churning and constricts the pyloric sphincter, which is here. Also, you have your secretion, which is released in response to acidity from the stomach. And this is released from S cells of the duodenum. It also causes alkaline secretion from the bile duct of cells, which is your bicarbonate. So things to remember: CCK in response to fats and secretin in response to acidity. And there is also some parasympathetic innervation of the gallbladder. Yeah. Okay, bile salt synthesis. I'm sorry if you can't read this handwriting, but yeah, it's the easiest way to make a diagram. So the synthesis. The synthesis occurs. It's not. Look, the L's look like the I's, and the I's look like the L's. Yes, it occurs in the liver, and 95% of your bile salts actually reabsorbed into your blood, and 5% are lost in your feces. So key steps to remember, you don't have to remember all of this, but you have your cholesterol and your precursors, and this turns into 7-alpha hydroxycholesterol in your liver. And this is kind of your rate limiting step. So this is what actually gets regulated and stops your production of bile synthesis. So you've got, it's negatively regulated, so inhibited by bile acids and salt and vitamin C deficiency as well. And obviously, if you have more cholesterol, you have more input into this pathway, so you get more bile salt production. So this 7-alpha hydroxycholesterol turns into your primary bile acids. There are some names I don't need to remember. And this is conjugated by glycine and taurine. So glycine and taurine are added to your primary bile acids, and that's what conjugation is. And the point of doing that is to increase your solubility and decrease your toxicity of your bile salts, bile acids, sorry. And once this happens, it turns into your bile salts, and then, funny enough, the glycine and taurine get taken out again, and this is done by intestinal bacteria, so your anaerobes, your secondary bile salts. This is all a bit of a mix-up of lots of words and stuff, but I think I put a video in the speaker notes that I found pretty useful. It does go a bit in depth, but if you want to understand the back of it, yeah, it's really good to see. Cool. Now moving on to your pancreas, so leaving the bile behind. Your pancreas has two functions. So it's got an endocrine function and an exocrine function. So what we're going to focus now is the exocrine, but just a bit of background. The endocrine function is release of hormones into the blood. And this is your diabetes related stuff. So your beta cells releasing insulin, alpha releasing glucagon, your delta releasing somatostatin and all that good stuff. So that's in your islets of Langerhans. And then the exocrine function is it involves your ductal cells, which secrete the alkaline pancreatic fluid. So kind of similar to bile, where it neutralizes your acid. And this is in response to acidity. And you have your acinar cells, which release enzymes in response to fats. So similar to your bile, so it's still in response to acidity and to fats. And just to get a picture of where everything is, you've got your pancreatic little globules, and you've got your duct cells here, and these are your exocrine cells. And your endocrine cells are separate, like your islets of Langerhans, they're separate. And again, these are acinar cells and your ductal cells here. And all these enzymes that are produced kind of come down through the pancreatic duct and join your duodenum. And it joins at, forgot what it was called, but it joins at the second part of your duodenum, and there's a little sphincter and a little pathway here. Name is also in the speaker notes, but yeah, just remember it joins in the second part of the duodenum, and it combines with your common bile duct, which is coming down here. So all of these come together and go into your duodenum. Does that make sense? Okay, so a bit of the enzymes that are actually in the pancreas. This is pretty in detail, but I think the important stuff to remember is, like, you've got your precursors, which are all precursors for the breakdown of proteins. And this breaks down the peptide bonds in proteins and activated in the duodenum. And then you have your carboxypeptidase, which is also involved in proteins. And this is specifically splits off the terminal amino acids from the carboxyl end of the protein, if you remember your protein structure. That one is not as important. What's important is your lipase, your pancreatic lipase. And that breaks down your fats and splits off your two fatty acids from your triacylglycerides. Important thing here is when you have pancreatic dysfunction, you don't get your normal secretion of lipase, so you don't get your normal breakdown of fat. So your fats can accumulate, and they can also come out in your feces, which is what causes your steatorrhea, or your like fatty stools. So you kind of can see how if any of these enzymes are affected, or if your pancreas doesn't work, all the breakdown of proteins and fats and polysaccharides and stuff is going to be affected. You've also got your amylase. So if you remember back to like year 12 chemistry, you have amylase in your saliva, which initially breaks down your carbohydrates, and then you've also got amylase coming out of the pancreas. So that breaks down your polysaccharides. And you have ribonuclease and deoxyribonuclease, which breaks down your nucleic acids. Okay, and now you've got something called trypsinogen, which is one of the precursors. So these are the activated names. So trypsinogen gets activated into trypsin. This occurs in the duodenal lumen. And what you need for this is an enzyme called enteric. And trypsin activates then your chymotrypsin and your carboxypeptidase. Not super high yield, but kind of shows how you need your precursors to be activated into the active enzymes, and then they go on to do their effect. Cool. And a lot of it happens in the duodenal lumen. So when you get your precursors released from the pancreas, they enter your duodenum, and then the activation happens. So just to get a sense of where everything happens, especially in the GI tract, when, or like in the GIT system, when there's so many different organs and enzymes, it's kind of useful to learn how to put it together, or like picture where things actually happen, because otherwise it can get a bit confusing, or you start just memorizing names and locations. Okay, so getting to the last bit of gut secretions too, we have pancreatitis. So there's two types, acute and chronic. And it's kind of what I was talking about when you have your lead-on effects from your pancreas getting affected, because it has a lot of functions. So causes of acute pancreatitis, there's a mnemonic called get smashed. So gallstones, alcohol, trauma, steroids, mumps, autoimmune diseases. Scorpion bite, which is a bit of a weird one, but you sound smart when you say it. Hyperlipidemia, ERCP is a process. It's kind of like a, let me just actually get it right. It's a endoscopic retrograde cholangiopancreatography. So it's basically like a diagnostic test, and the way that causes pancreatitis is if you have mechanical injury from like the camera actually going in, and certain drugs. And the classical buzzwordy presentation is the patient usually has severe and constant abdominal pain, which radiates to the back, and it's made worse by moving and relieved by sitting forward. And you have nausea and vomiting, which could just be due to the pain. And treatment of this is usually supportive treatment. So you need to be pretty quick because the patient is in severe pain. And rapid IV fluid replacement, pain relief, anything to make the patient comfortable and prevent further progression of the disease. And then you have your chronic pancreatitis, which isn't as acute and intense. So your back pain is more constant, but it's a bit more long-term than just your like sudden onset. 90% of the cause is actually excessive alcohol intake. And it's due to defects of the ductal cells. So if we go back here, the ductal cells are kind of these things which secrete your bicarbonate. And this results in no bicarbonate and no pancreatic enzyme activation. Usually the presentation is constant abdominal pain, similar to this, but it won't be as severe. Weight loss and steatorrhea, like we said, because of the loss of lipase. And treatment is usually complete abstention from alcohol, pain relief, and supplements. Cool. Now I'll hand over to, I think, Alex, who's going to go through part 1, even though it's after part 2. Any questions before I hand over? Okay, looks like no questions. Move on to Alex. Thank you.
Thanks. Can you, yeah, thanks. I'll just get the slides shared up. So, hi, I'm Alex. I'm going to go over part 1 of the gut secretions. My internet might not be the greatest, so let me know if I start to cut out, but I'll get started. So, funny enough, when we start with gut secretions, we start with the mouth because digestion actually starts at the mouth. You've got your saliva, which has multiple functions. The way you can think of it is that each of the compositions of saliva have their own role in governing how saliva does its job. So you've got ions, you've got tiling, you've got mucin, immunoglobulins, and then you've got water, which roughly makes up 97 to 99.5% of it. So as a result, from those 5 compositions, you get 5 roughly functions. You get protection from the ions, where the ions in your saliva are responsible for the rinsing in your saliva, because your saliva kind of sits in your mouth and rinses the teeth, and the calcium phosphate in it prevents the teeth from demineralizing and ensuring that the teeth is in good health. There's also the fact that the ions in saliva is slightly alkaline, and this serves as a protection against acidity, where you have stuff such as reflux. It's not going to protect you from drinking hydrochloric acid, but it's there to protect you if you have reflux. You've also got the digestion aspect of saliva, because digestion begins in the mouth actually. And that's where is the salivary amylase, which I think was mentioned before. The salivary amylase, also known as tiling, and that's what initiates the carbohydrate and starch digestion before it goes down to your stomach and intestines. You've also got mucin, which lubricates the ingested food, allows it to be pushed through much easily. You've got immunoglobulins, which are responsible for the antimicrobial effects. This is what prevents the microbial colonization of your mouth. So if you don't have much saliva, that's an issue. And also water, which has water-assisted function governing speech, absorption, and taste sensation. Your saliva acts as another kind of lubricant to help your tongue move around. A stiff tongue, if your tongue isn't well hydrated, it will be quite stiff and not easy to move around. It is also helping absorb drugs. So when you have sublingual drug absorption, so stuff like GDN, I think, this helps with the absorption of drugs. You've also got the absorption of tastins, which are responsible for the taste sensation. So because food has chemicals known as tastins, which are responsible for having the taste that you have when you eat, and that's also dissolved in saliva. Now, saliva is governed by the parasympathetic nervous system. What happens is, first, you've got the higher sentence, the brain cortex, which sends stimuli of food. So that's stuff such as the touch, the taste of the food being present, as well as even the smell, sight, and even sound. So like barbecue sizzling, for example, and thought. All of these trigger your brain to think, oh, there's food coming. So they start to prepare the saliva. As a result, you get the olfactory, gustatory, visual, and auditory cortexes of your brain activating, which sends signals down to your medulla. That's the brain stem. Here, the impulses can be modified because you have stimuli such as sleep and fear, which inhibits that saliva, because when you're sleeping, you don't really want to salivate, and when you're scared, that's not really time to eat. So then from there, the brainstem sends signals to the parasympathetic nervous system down to the salivary glands. Your salivary glands, you have about, you have your intrinsic buccal glands, so the ones in your cheek, and also the 3 extrinsic ones, so parotid, submandibular, and sublingual, which are connected by ducts. So basically the parasympathetic nerve system innervates the salivary glands, and you have acetylcholine from these nerve terminals activating muscarinic receptors. And this triggers stretching of salivary cell membranes, causing an increase in salivation. So main thing to take away is that acetylcholine and parasympathetic nervous system are responsible for your salivation. There's also nausea, which is another stimulant of saliva. Like I mentioned, your saliva is alkaline, so it protects from acidity, and vomit is acidic. So as a result, when you're nauseous, when you start to vomit, the brain starts to prepare saliva to protect itself. And yep, and as a result, saliva, you can get either too little of it, which is xerostomia or dry mouth, or too much of it, which is drooling or tylism. So the xerostomia is probably a more important one to know, but as a result of it, you don't have saliva. What do you have? You don't have the functions that saliva brings. So you get oral, dental, gum disease, bad breath. That's because you don't have the ions or the immunoglobulins against bacteria. You've got compromised chewing and swallowing because you need tiling to digest the carbohydrates. You need mucin and water. You don't have. And because there's no water, you have compromised speech, and also you start to get altered taste and thirst. A way you test for xerostomia is the dry cracker test, which is where you give them a cracker and get them to try and chew it, because they don't have the saliva. They don't have the proper ability to chew onto it. You can't digest it well either. And there are many causes of dry mouth, but radiation, dehydration, shock, renal failure. But the ones probably important to know is it can be caused by drugs, most commonly tricyclic antidepressants, which you'll touch on in semester 2. And of course, the treatment, well, the problem is that the muscarinic receptors aren't triggering the salivary glands to produce saliva. So the treatment is to use muscarinic agonists to stimulate them, and also remove the offending drugs such as tricyclic antidepressants. There's also artificial saliva, which is basically just water, which honestly doesn't really work because, well, it doesn't really have all the composition that normal saliva has. And then tylism, which is overproduction of saliva. Again, it's mediated by acetylcholine and parasympathetic nerve system. So therefore, if you want to decrease the signal, decrease the saliva, you decrease the signals. And that's why the treatment is anticholinergics, mainly atropine. Though you do have to give small doses because atropine also inhibits gut motility, systemic side effect in high doses. Now, swallowing. So swallowing can be divided into 3 phases: the buccal, in your cheeks, the pharyngeal phase in your pharynx, and then esophageal down your esophagus. And so swallowing starts in the mouth. It starts when you form a bolus with the food, like kind of push it into a bolus and push it to the back of your mouth. This process is voluntary, but once it starts to get the back of the mouth and tries to go lower, you have pattern recognition, which senses whether the food can be swallowed or not. This slowly becomes involuntary, and it's there because you don't really want to swallow something you can't swallow, otherwise you choke. And in this phase, you got the tongue contraction, pushing the bolus to the pharynx, and then it activates the touch sensitive mechanoreceptors in the pharyngeal wall, allowing to be trigger the pharyngeal phase, which is involuntary, and it starts to push the food slowly down. The uvula rises and closes off the nasal passage. You don't want food coming out of your nose, and also the epiglottis closes off the trachea because you don't want to breathe food. And afterwards, when it starts going down the pharynx, the upper esophageal sphincter also relaxes, allowing to continue down. And to the esophageal phase, which is also involuntary, you can split into voluntary phase, which is buccal, and then involuntary, which is the rest of it, basically. And it pushes through the sphincter into the stomach, where you have the peristalsis in the stomach. That's where you've got circular muscle constricting behind the bolus, pushing it forward, and longitudinal muscle shortening ahead, allowing it to travel ahead. And now onto neuronal control, because well, this is somewhat important, mainly the skeletal muscle and smooth muscle division of the esophagus. But again, there's voluntary, involuntary. So voluntary is your higher centers, your brain doing all the work there. Involuntary, which is pharyngeal esophageal, is controlled mainly by the brainstem swallowing center. So you have mechanoreceptors that project there, telling your brainstem that, oh, there's food in your esophagus and your pharynx. So you've got your efferent impulses, which is mainly the vagus nerve, controlling your involuntary phases. So that's the peristalsis movement of the esophagus. And that's further divided into skeletal muscle or smooth muscle, where you've got the top third and part of your middle third, which is the pharynx, early esophagus, and upper esophageal sphincter. That's your skeletal muscle. and your smooth muscle, which is part of the middle third, and your bottom third, the lower esophagus and lower esophageal sphincter, and that's the smooth muscle. So the skeletal muscle is controlled by somatic nerves, while smooth muscle is controlled by parasympathetic and enteric nerves. So, and the way you think of it is esophagus, three segments, top or bottom. The top is skeletal, the middle is mixed, and the bottom is smooth muscle. Your vagus nerve, which is the one that's mainly controlled both pharyngeal and esophageal involuntary phases, contains the somatic and parasympathetic nervous system. And it also plays a part in the gag reflex, because remember those touch mechanoreceptors I told you about? Well, like that's mediated mainly by the glossopharyngeal sensory nerve, which senses whether there's food there, whether there's something there, and you've got your vagus motor then carrying out the gag reflex. So when you got two large objects, the body tries to contract and restrict to try and cough out or eject the object. Incidentally, there's something known as sword swallowing, which is when people try to lie down the sword down and kind of swallow the sword. This the way they do that is they place the sword in a way that it doesn't touch those touch receptors, and it doesn't, well, try and cough out that sword, because it's quite dangerous when that happens. And of course, there's disorders with swallowing as well. So common causes are, you got mouth, tongue, salivary problems. Again, digestion starts up there. If there's impaired, you're going to have trouble swallowing as well. You got your pharyngeal esophageal problems, which is like lower part of your swallowing phases. That's, you got stuff there such as outpouchings or diverticulums, which are kind of like trenches in a sense, where the food kind of gets stuck there. You've got sphincter disorder, which can be related to neuromuscular disorders, where the main one is achalasia, which I'll talk about. And you've also got post-stroke and Parkinson's, because the neuronal control is a bit impaired, which sometimes is why you have choking in Parkinson's patients. So with sphincter disorder, the main one to know about is achalasia, which is a nervous sphincter problem. Essentially, the enteric nerve cells, so that's your smooth muscle control, they become degenerated and non-correctable. It's irreversible. And as a result, the lower esophageal sphincter can't really relax. As a result, the treatment, because you can't correct the nerves, is you send an endoscope down and you dilate the sphincter with a balloon. So you kind of like, it's kind of like comes down here into the sphincter area, and when it in the kind of narrow area, the balloon kind of expands. But there's problems with that, because it can cause tearing, and it's not the best. And you can also kind of inject Botox to kind of paralyze the muscles to allow the food to come through. And now finally we get to actual gut secretion, which is done by the gastric pits in your stomach. So there are four main types of cells you need to know about: the mucus cell, parietal cell, that's probably the most important one, sheath cells, and the enteroendocrine cells. So you've got your mucus cell secreting mucus, again, for lubrication to keep the food going in your stomach. You've got your sheath cells, which are the ones here secreting pepsinogen. Pepsinogen is in the inactive form of pepsin. It doesn't do anything by itself, but once the environment is sufficiently acidic, so pH 2, the enzyme is then activated and allows it to break proteins down into peptides. And how do you get the environment to be acidic? Well, you get your parietal cells, which secrete hydrochloric acid and intrinsic factor. So intrinsic factor is critical for B12 absorption. Lack of it will result in anemia, while hydrochloric acid has quite a lot of functions. It, as I just mentioned, activates the pepsinogen by controlling the pH. It also kills ingested bacteria through sterilization, and also it's needed to break down cellulose in plant cells. And on top of that, you got your enteroendocrine cells, which are your ECL cells and G cells, and they secrete either histamine or gastrin to aid in your acid secretion. And normally your gut secretes acid at a baseline level known as base acid secretion. Essentially what happens is you have carbon dioxide, which is generated either by metabolism or digestion in your stomach. It comes into your parietal cells, where it dissociates in the presence of water it converts in the presence of water to carbonic acid, which dissociates into hydrogen ions or bicarbonate. So now you've got the hydrogen bicarbonate. So the bicarbonate is exchanged for chloride, which enters this, and the bicarbonate then leaves the parietal cell and entering the stomach, draining into veins. So that's something to keep in mind, because there's a phenomenon known as the alkaline tide, which is the phenomenon of having more hydrochloric acid in your veins than arteries. And that's caused by the bicarbonate that's exchanged for the chloride. And then once you've got the chloride in the parietal cell, you've got to secrete it, and it leaves the cells through those chloride channels over here in the diagram. And now you still got hydrogen ions in the parietal cells. You've got to secrete that as well to get hydrochloric acid. And it's done against the concentration gradients through proton pumps, which you can see over here in these little trenches. They're on the lumen of stomach lumen, and it pumps potassium in against the gradient and hydrogen out against the gradient. And as a result, because it's against the gradient, this requires energy, so ATP. And now, sometimes you want a little bit more oomph. You sometimes want more than basal acid secretion. So within your cytoplasm, you have receptors for gastrin, which are the G-type receptors, acetylcholine, which is your muscarinic receptors, and also somatostatin, your S-type receptors. The first three, gastrin, histamine, and acetylcholine, are responsible for increasing the acid secretion, while somatostatin is responsible for inhibiting that secretion. So what happens when these receptors are triggered? They trigger the secondary message system, so cyclic AMP, and it kind of sends messages from the receptors down to the lumen, where it inserts more preformed proton pumps into the parietal cell luminal membrane. Think of it as a sink. When you've only got one tap, there's only so much water you can let through. But if you add more taps, then that's a lot of more water you're getting through. So that increases your basal level acid secretion. On top of that, the acetylcholine and gastrin secretion also acts further on the histamine cells to release more histamine as a sort of positive feedback loop, increasing acid secretion. So there's three main phases that of increasing gut secretion. So as you mentioned before, your brain starts to notice when food comes by, so it starts to prepare the gut secretions. So you got your vagus nerve from your brainstem telling the acetylcholine and gastrin receptors to start releasing some of that, and triggers the ECL cells to release more histamine to get the acid ready. Then you've got your gastric phase, where the food is come from the esophagus into your stomach. So then your stomach starts to distend, starts to stretch, and the semi-digested proteins, as well as alkaline acid conditions, tells your body that, okay, we need a bit more acid to help in digestion. So you've got your enteric, which is the local nerves, and then your PNS autonomic reflexes, releasing acetylcholine, gastrin, and increasing histamine as well to get those proton pumps inserted into the lumen. And once your digestion is done, so once the chyme gets emptied into your duodenum, the intestinal phase begins, where the protein digestion products and the acidity of your body, the acidity of the environment tells your body now it's time to stop this gut secretion. You get the secretin gastric inhibitory peptide being secreted, which are your inhibitory modulators. And also the enteric and vagal nerves get kind of blocked as well. That in turn stops acetylcholine and gastrin from being released. So what happens when you have problems with gut secretion? So problems, how do you define it? That's when acid secretion is above that basal level too much. And it's seen prominently in gastric ulcers. So the way you treat it is two main drugs. So you use antihistamines, because remember how acetylcholine and gastrin releases histamine. So rather cut out the middleman and go into and target histamine directly to stop those proton pump inhibitors inserted. Or additionally, if you want something a bit stronger, is you just target those taps themselves. You target those proton pumps, then you have proton pump inhibitors, which are drugs ending with prazole. And yep, that's pretty much all gut secretion. If you have any questions, feel free to ask them now. In that case, I'd probably just hand it over then.
Yeah, thank you, Alex. Will I be able to share screen? Share my screen? Yeah, thank you. Yep. So I'll be going through gut motility this week. Just what's normally supposed to happen. So as you're probably aware, our gastrointestinal tract is made up of the small intestine and the large intestine. So the small intestine is obviously what comes first. It starts at the pyloric sphincter straight after the stomach and ends at the ileocecal sphincter, approximately where the appendix is. And these are some values of the lengths of each section of the small intestine, starting with the duodenum and ending with the ileum. These values, they haven't been, I guess, assessed before in the exam, not that I know of, but it is good to know just to have an idea of how long the small intestine actually is. So the duodenum is quite a short length. It's just like the little curve, which quickly progresses to the jejunum and the ileum, which is the longest. So what occurs in the small intestine is that chyme from the stomach, just that ball of food is mixed with digestive juices, namely gastric acid, and it's slowly moved along the short intestine. Chemical digestion is completed by the end of the small intestine. And the important thing to remember is that nearly all nutrient absorption occurs in the small intestine. So any dysfunction along the length of the small intestine will greatly affect, depending on obviously the part of the small intestine that's affected, a type of nutrient absorption. So for example, iron or things like B12, which will be covered, I think, later. So, and at the end of the small intestine, the undigested remains are moved to the large intestine. As for the large intestine, it's mostly all about absorption. So reclaiming all of the water and electrolytes present in the food. So a lot of what occurs is mixing contractions and also a lot of chemical digestion by enteric bacteria, as well as propulsive actions and excretion. Those two obviously go hand in hand. And it starts with the cecum, to which the appendix is attached. So you can see there in the diagram. And it quickly progresses to the ascending colon, to the transverse colon, to the descending colon, and then sigmoid, rectum, and then to the anus. So I think one of the facts that was mentioned during the lecture is that the large intestine isn't actually essential for life, which came as quite a surprise to me. But I think it may stem from the fact that all nutrient absorption has occurred already, and it's mostly just a bit of chemical digestion by bacteria and a lot of absorption here. So the most important part of this lecture and what you should take away with is just all the different movements that occur in a normal person. So all of like how food is mixed and how food is moved along the length of the intestine. So I think one way to do this is to sort or split the movements into mixing and propelling. So mixing, as you can imagine, is just moving the food just in a certain length of intestine. It's not moving it forward or backwards, but just keeping it there, but just getting it all mixed up. And propelling is, of course, moving it along the length for the next process. So there are very specific names for each movement. So in the small intestine, you've got mixing movements, which are called segmenting contractions. And the propelling movements, the movements that once everything's done in the small intestine, everything gets moved to the large intestine. Those movements are called part of the migrating myoelectric complex, which is also called MMC. In the large intestine, the equivalent of the mixing movements in the small intestine are now called haustral contractions, named after the haustra, the little sacs of or folds in the large intestine. And the propelling movements are very aptly named mass movements. So segmenting contractions, I'll just show an image of this, is essentially localized constrictions of a small intestine that when they occur, they end up looking like a string of sausages. So it's good to keep in mind that there is no actual net movement. So it's more of a one step forward, one step backward kind of deal. So as you can see in this image, each ball of food only really moves like backwards and forwards within its own range. And over time, the result is that everything gets mixed together more. So all the bile salts and all the excretions from there get mixed up evenly with the food. So the main purpose here is just to allow for the chyme that came from the stomach to mix with all the digestive enzymes being released by the pancreas and by the gallbladder to be chemically broken down. The migrating myelectric complexes occur when most of the meal has been absorbed. So the segmenting contractions have done their thing, and the MMCs are needed to move everything to the large intestine. So there are a few values to these contractions. So they're about 60 centimeters per contraction. And the whole process of moving the food along the small intestine takes about 2 hours. And you need this movement just to prevent the overgrowth of bacteria. So making sure the food moves along and there isn't any like stasis that allows for bacteria to accumulate. So there are a few triggers, physiological triggers that for the MMCs. So it's initiated by rising pH of the chyme, which suggests to the body that the digestion is nearly done. So all that acid has essentially digested all the food and it's no longer as acidic, or an increase in an enzyme called motility in the plasma, which I think will be learned later in nutrition, but its feeding essentially inhibits its release. So once it rises, then it's a signal that everything's done, feeding is completed, so it's time to move on. Yeah, it's just an image once again of the segmenting contractions in the small intestine. As for large intestine, once again, you have the same equivalents. So here, the house contractions are the mixing ones, and you can see the individual haustrum or haustra in the diagram below. So they basically small pouches which give the large intestine that very classic segmented appearance, so little balls. And food approximately mixes about a rate of moving along 3 haustra every 30 minutes, which allows plenty of time for water and electrolyte absorption. As for the mass movements, that's the simultaneous contraction of really long segments from start to finish. So there's a basically the haustra disappear and you instead just get a really smooth constrictive ring that pushes all the food forward. And it's about 30 seconds per contraction at a rate of about 3 to 4 a day, but up to 10 is normal. So what's important here is just what triggers what. So here, when food reaches the stomach, a few things are triggered and a few things are inhibited. So the first of which is segmenting contractions. So segmenting contractions are triggered by stomach filling because the small intestine basically prepares itself in advance to start mixing for all the food that's about to come in, whereas migrating myelectric complexes are inhibited because otherwise you'll be pushing undigested food straight to the large intestine. As for haustral contractions, they're triggered locally only. So if food gets propelled from the small intestine to large intestine and it presses on the stretch receptors in large intestine, that's just a local trigger for haustral contractions to occur, because if it sees food, it mixes food. If there isn't, then there's no mixing to occur. And for large intestine mass movements, that's once again also triggered by stomach or duodenum filling. And the rationale for that is that if new food is coming into the body, well, then we need to make way for that food. And that's why mass movements occur, to evacuate what's already been pretty much digested in your body. So that's the end of regular motility. So I'll leave it to Omandi to discuss what happens when motility doesn't go as planned.
Yo, hey, I was just wondering, can everyone see my slides or no?
We can, but we can see the Zoom thing as well.
Oh, frick, okay. Is this
Beautiful.
better?
That's perfect.
Okie doke. If this works, that would be amazing. If not, I will start crying. It's fine.
I can share.
All right, I think Okay. Is this all right?
Yeah, that's good. It's just not full screen,
Ah, frick.
but that's fine. I can share for you if you. Oh no, you've sketched it, haven't you?
Oh,
I
well,
can
like
share.
the sketch is kind of on the thing. Yeah. Should we do that then?
Yeah, let's do
All right,
that.
I'll stop sharing.
Let me
Thank
just
you.
remove my thousands of tabs. Okay. Share screen. Let's find it.
Yeah. Sorry about that, David.
That's okay. It happens. How's that?
Yeah. Beautiful. Slide in. Oh, okay. Yeah. So if we can just skip through these two, because I think Daniel's kind of covered these slides. All right. So beautiful. Gut motility. So yeah, I'll just be covering a little bit more on this and then moving on to just motility as well. So starting off with this, I think by now we should know that like gut motility is the proportion of food through the gut. Something that I just want to cover quickly is that you've got like two different types of smooth muscle within the gut, right? So you've got the longitudinal smooth muscle, which in my like really random crappy diagram that I made last year to kind of understand this concept a bit better, it's the green cells. And basically when these cells contract, because they're sort of like following the direction of the gut, where they contract, it actually causes your gut to become shortened. And then conversely, you've also got circular smooth muscle, which is perpendicular to the gut tube. So when they contract, you actually get constriction of the gut tube. And it's this combination of shortening and constriction that sort of forces food along the gut tube. So yeah, there's that. Next slide, please, David. Beautiful. Sphincters. Again, not super high yield, but basically they're just like areas along the gut tube that are consisting of like thick and smooth or skeletal muscle. And the really important thing that I want you guys to take away from this is that the upper esophageal and external anal sphincters are skeletal muscle sphincters. So this basically means that they're under voluntary control, right? As opposed to all the other sphincters that are in between that are smooth muscles. So they're not under voluntary control. And this is really important later onwards when we talk about the defecation and the reflex. But yeah, those are your sphincters. Next slide. All right, so nerves. There are a bunch of different types of nerves that innervate the gut. So if you start off with your sensory nerves, so chemoreceptors, they kind of respond to a change in pH. So for example, with the migrating myoelectric complex, which I'm assuming David touched upon earlier onwards, it's actually an increase in pH that helps with like initiating that change from segmenting contraction to like the migrating myoelectric complex. And then similarly stretch receptors, so they kind of detect a stretch in the gut wall. And this is actually really useful in a number of different ways. But for example, when you got that chyme moving in from your stomach into your small intestines, it's the stretch receptors that sort of initiate the segmenting contractions. And then you've got your autonomic nerve fibers, so your parasympathetic, which is your rest and digest. And obviously, if you're digesting, then that's going to lead to an increase in motility and also gland secretion. And then conversely, sympathetic is your fight or flight. So that's going to lead to a reduction in digestion, so reduction in motility and gland secretion. And then, as I touched upon before, you've got your skeletal muscles, which are under the control of your somatic nerves. And then finally, you've got your enteric nerve fibers. Next slide, please, David. So yeah, basically your enteric nervous system is a nervous system that is located entirely within the gut. So it's like intrinsic. And it's really cool because it can actually control the gut independently of the central and autonomic nervous systems. So for example, if for some reason your autonomic nervous system is malfunctioning, not really working, the gut can still use the enteric nervous system to still do some form of like motility and like moving things along the gut. So within the intrinsic nervous system, we've got two different plexuses. So we've got the myenteric plexus, and that's located within the layers of your circular and longitudinal smooth muscle, which I talked about before. And this is kind of like as you can imagine, if it's located within the smooth muscle, then obviously it's going to be like involved with like motility. So yeah, the way I remember it is like enteric, muscle, motility all begin with M. And then conversely, you've got the submucosal plexus. And as the name suggests, that it's located in the submucosa. And that doesn't actually do a lot of like motility control, but it actually just controls glands instead and like secretion. And it has a role in nutrient absorption as a result. And it's actually not located within the entire length of the gut, but only in like discrete regions. And again, submucosal and secretion begin with S, and that's how I tend to remember that. And just like the autonomic nervous system, the nerve fibers can be either excitatory or inhibitory. So usually if it's acetylcholine mediated, then it's excitatory and leads to like more motility and secretion. And if you use like nitrous oxide, it tends to be inhibitory, which helps with like relaxing smooth muscle. Next slide, please. All right, so this is just a table I ripped off PSPU, but I'll just very quickly run through this. So as we touched upon before, sympathetic nervous system, that's your fight or flight. You're trying not to digest things because you're like trying to run away from a serial killer. So motility is obviously going to decrease. Your secretions are going to decrease, and your sphincters will constrict to prevent the passage of food through the gut tube. Conversely, parasympathetic, that's your rest and digest. So your motility is going to increase, your secretions are going to increase, and your sphincters will relax in order to allow the passage of food through the gut tube. And then my enteric complex, remember that's a part of the enteric gut nervous system, but that mainly controls like muscles. So yes, when you excite it, you're going to have an increase in motility, and then inhibitory will like lead to a decrease in motility. But it doesn't play a role in secretion, so no real change there. And for some reason, if you inhibit the myenteric complex, that actually leads to the relaxation of the sphincter muscles. I'm not entirely sure what the mechanism behind that is. I tried Googling it, couldn't really find anything. But yeah, that's what the lecturer said, so just chuck that in there. And then submucosal, that's involved in secretion, so really no change in motility. But if you excite it, you're going to have an increase in secretions. And then conversely, if you inhibit it, decrease in secretions, and it doesn't really affect your sphincters. Next slide, please. Amazing. Okay, so we finally arrived at the defecation reflex. And I know this looks a bit overwhelming, but we'll just kind of break it down and go step by step. So your defecation reflex basically starts when you have a mass movement, and that pushes your stool from your sigmoid colon into your rectum. And when this happens, the presence of the stool actually activates the stretch receptors that we talked about before within the rectal wall. And therefore, like the sensory nerve fibers then send a signal to your spinal cord. And this leads to a bunch of different both involuntary and voluntary movements. So from the parasympathetic side of things, because obviously rest and digest, this will lead to rectal contractions, and that actually allows the movement of the stool through the rectum, through the anus, and then obviously out. And then also internal anal sphincter relaxation, which is really important for the passage of the stool as well. And then similarly with the enteric, so from the myenteric plexus, which controls your muscles, this allows for more rectal contraction and also internal anal sphincter relaxation. And then sinus submucosa is responsible for secretions. This leads to an increase in mucus secretion, which helps move the stool along. And then in terms of voluntary movement, as I touched upon before, your external anal sphincter is a skeletal muscle sphincter, and therefore it is under voluntary control. So you actually have the like capacity to decide, okay, whether or not you want to go to the toilet. So when you decide you do want to like pass a bowel movement, this actually leads to the inhibition of your somatic nerves, which leads to the relaxation of your anal sphincter, and then you have a bowel movement. While conversely, if you decide that you don't want to go to the toilet, this leads to excitation of your somatic nerves, which control your skeletal muscle. And then this leads to a contraction of the muscle, and therefore the stool can't pass through. And then if you choose not to have a bowel movement, the stool actually goes backwards into the sigmoid colon via retrograde peristalsis.
So yeah, that's motility. And then moving on to dysmotility now. Next slide, please. All right, so first of all, you got constipation. So the definition of that is basically either passing stools less than 2 times a week, if you've got straining more than 25% of the time, and if your stools are really hard or you've got like incomplete evacuation. And then you've got like 2 types of causes for constipation as well. So you have like slow transit, which is basically just like poor motility. So it's like difficult to move the stool along. And then you've got obstruction. So as you can imagine, if you have like some kind of mass, like say a tumor or something, that's like physically blocking off the gut tube, the stool can't actually move past that and be passed out. So that's obstruction. And there are a couple of different like conditions or like even just like lifestyle factors and stuff that can contribute to constipation. And that includes like pregnancy, obviously inadequate fiber intake, immobility, irritable bowel syndrome, and iron. Iron's really important because when we talk about anemia in semester 2, and you give patients like iron supplements to help with like counteracting that, one really important side effect that you'll have to mention is that like it could lead to constipation. And then similarly, you've got antidepressants and then hypothyroidism. So when we talk about the endocrine system later on this semester, one of the presentations of hypothyroidism is going to be constipation. And then obviously intestinal obstruction will lead to constipation as well. As the main treatment, really important that we treat the underlying cause. And then if the cause is like poor motility, then you'd recommend that your patient increase their fiber intake. And then for more severe cases, you can use laxatives or even manual evacuation, which is just kind of like scooping the poop out, which is really gross and not a pleasant experience for either party involved. So that's constipation. And next slide, please. Finally, we've got diarrhea. So basically, that's just a rapid movement of fecal matter through the large intestine. You've got 2 types. You've got the organic, which is just inflammation of your lining, and then functional, which is damage to your muscles and to your nerves. A couple of main causes, just like enteritis, ulcerative colitis, general malabsorption, hypothyroidism. So on the flip side to hypothyroidism, which can present with constipation, hypothyroidism can present with diarrhea. And then like obviously lactose intolerance is like a typical one, and inflammatory causes. So like this leads to like the destruction of your mucosa, and that also leads to like loss of fluid and a lot of blood. And the treatment, really important that we treat the underlying cause. And obviously if it's like diarrhea, your patient will likely be dehydrated. So it's super important to give them oral fluids and electrolytes. And you may also need IV fluids if the diarrhea is really severe. So yeah, that's gut motility and dysmotility, guys. I'm gonna pass it on to Alex for EBCP, EBM, EBM. Okay, have fun. Bye.
Thanks so much. Welcome back.
I'm just gonna share the slide, sorry, bear with me.
Thank you.
So welcome to EBM, not exactly high yield. So what's EBM? It's about how to have an opinion. So basically it's kind of important actually, because when you're a doctor, you're giving your opinions and advice to the patient. So when you look up articles, you need to know, what did you search? What did you find? What supported the reasoning? What contradicted the reasoning? And the way you assess the article is look for its validity. Is it valid? Is it reliable? In terms of validity, you have external validity, which is the question appropriate? Is it generalizable? Is it applicable? Applicable as in, do the results help? Can they be extrapolated? Do the benefits worth harms and costs? It's no use if the article details a life-saving intervention that's that costs millions of dollars, because not everyone's going to be able to get that treatment. And then also you have internal validity, which is the research question asked correctly? For example, if you've got an article investigating whether cannabis helps with PTSD, make sure that they're actually measuring that and not measuring another outcome such as depression. And also internal validity is the bias, and how do they combat that? And in reliability is whether it can be reproduced. Is there a consistent measure? So not looking at stuff as one-off miracles, it's got to be able to be replicated. And also the degree to which the estimates are consistent. You don't want it going all over the place. And also whether the results themselves are consistent within the test itself. So when you find an article, the way you choose it is you base it on quality, selection. The information is dependent on the original articles. So when you're appraising an article, it's important there's quality, this is selected properly, measurements are done properly, that confounding is adjusted for, because the differences in population setting, study results, generalizability, intervention, and measurement. And also make sure there's a careful, valid assessment in each article in each study. And that's especially relevant to meta-analysis or systematic reviews. And biases. So in terms of internal validity, there's many sources of bias. So you have baseline imbalance is an important factors. For example, when you're testing only Olympic athletes, they generally have a lower heart rate, which might not reflect the average population of the patients. Is there contamination? For example, did they account for bias? Was the patient who was, when they were testing the intervention, did they make sure that the patient wasn't having other forms of treatment that might have impacted the results? And also inappropriate influences of funders. So for example, make sure the article into cannabis testing, for example, isn't done by somebody who works for a cannabis company, because that's probably an influence. And there's also lack of washout periods in crossover trials. So crossover trials refer to trials where you have two groups of patients, group A, group B. Say group A takes intervention first and group B is control. After they go through that event, after a while, they swap around. And so now group A gets control and group B gets intervention. In this way, all the participants get to try out the intervention and control, but you need a washout period, which is when the patient should not receive any intervention before continuing to the next stage of treatment, because otherwise you might have lingering effects that affect the results you get. And there's also double publications, which is especially relevant in kind of meta-analysis and systematic reviews, because this can lead to overrepresentation of one review. So stuff such as interim reports, which are basically updates on previous reports, and also salami publication, where you've only had one study, but someone wrote 2 articles for it to butter stuff up. And now you've got your levels of evidence. So on the bottom, you've got editorials, expert opinions. Then you got case studies, case reports. You got where like basically they just write about some interesting patients. Then you got case control studies, your cohort studies. RCTs are the highest level of experimental studies, but on top of that, you got systematic reviews, which what they do is they appraise and synthesize many primary research papers to minimize bias. It's important because compared with something else known as narrative reviews, which is quite low yield, there's also called literature reviews. Systematic review requires rigorous standards. So it needs to have a good search strategy, it needs to be documented, and it needs to have a good selection criteria, which also needs to be documented. What's important with systematic reviews, they draw all info into relevant clinical questions. Conclusion lays out facts we know more comprehensively, and it's much more efficient to read one systematic review than 90 randomized controlled trials. And on top of systematic reviews, you've got meta-analyses. So these are the facets of the systematic review: ask, acquire, appraise, apply. Those parts of EBM leads to formulate question, develop protocol, literature search, assess the studies, data extraction, data synthesis, and then interpret it. The advantages is you get condensed, objective, verifiable, replicable information. It's flexible because you can easily update it, add a new study to the systematic review, and also dynamic because when you're going through a systematic review, you'll notice if there's certain areas that haven't been researched well, and also can tell you what we should research next. The disadvantage is that, garbage in, garbage out. If it's poor quality, then you have difficult time, it becomes difficult, time consuming, and also there's lots of collaboration. So any of that falls apart, the whole thing falls apart. It's also contentious because sometimes systematic reviews can disagree with the trials themselves. And also there's inappropriate aggregation because ideally, you'd have studies studying the same topic, but they might differ in certain ways. So for example, some might be looking into wounds after skin grafts, others might just be looking at leg ulcers, which means that you can't, sometimes pulling them together can cause a bit of problem. There's also disagreement. Some systematic reviews disagree with each other, so you have to think, which one do I listen to? And also systematic reviews ultimately come down to a final verdict and judgment. So it's may not be the best for studies that, some studies that don't exactly give a judgment, but kind of just information. And the other type of high evidence is meta-analysis, which you may see in systematic reviews, but it's not necessary. What it does is it statistically combines the results from 2 or more separate studies and kind of plots it. So you see your forest plot there. The square is the mean of the study, while the line is the confidence interval of the results. And the diamond is the pooled mean when all the results are averaged. And the size of that diamond determines the confidence interval size. So some things to be cautious about is, again, garbage in, garbage out. So sometimes if the topic is quite small and there's not many trials, it can later cause your meta-analysis to be outdated when the larger trials are done, changing the results. And also, is it clinically relevant? Because again, if a meta-analysis is dramatically better than what the individual trials report, then be careful. It's probably dodgy. And again, you've got your same sources of bias, so selection bias, what studies you chose can affect the results, information bias, measurement errors affect the meta-analysis funnel plot. Also, confounding and chance can cause problems as well. Is the plot that plots individual study results on the x-axis. So either favoring or not favoring treatment. Then you got measure of study on the y-axis. So the idea behind it is that larger sample, there's less variability. So you've got more around the center, while if it's smaller numbers, so those studies with smaller populations generally kind of, there's more error, and as a result, there's greater variability on either side. So the idea behind it is normally you'd get a lot of studies that around the center of where the true value lies, and then you've got your outliers on either side. So as a result, this is a good way of visualizing it, because if you have publication bias, so that's like over-reporting of positive results and under-reporting of negative results, you get stuff such as skewed plots, where there's a lot of, where it seems to be there's a lot of missing information about whether there are studies not favoring the intervention. There's also other types of ways that publication bias may manifest, such as a hole in the funnel plot around the middle region. So that's like 2 extremes with no in between. And sometimes also overestimate of pooled effects, where you don't, if you don't have too many studies, sometimes you have a lot of smaller studies saying the same thing, but it's kind of unreliable because you don't really know how reliable that is. And that's pretty much EBM. If anyone has any questions. Honestly, EBM isn't that useful.